Okay. Testing 1 1, testing 1 1. Testing 1 2, testing 1 2. Testing 1 3, testing 1 3. Testing 1 5, testing 1 5. That's the Reverend. Yes, sir.
There you go.
Testing 4 1, presenter mic. 4 1. Testing 4 1. Little hot, just a little.
We are waiting on a quorum check, so bear with us.
Just saying, yeah, we have a new committee,
Okay.
so she'll replace.
Okay, we have quorum, so we'll go ahead and call this meeting to order. Welcome to the Quality Committee, Monday, February 13th, the day before Valentine's Day. So if any of y'all have forgotten, this is your official reminder. You will have no excuse, and it will actually be probably on the web. So last year we had it on Valentine's Day, so I didn't get a chance to remind you, but this year is different. If we have any citizens wishing to address the committee, I've been told there are none. And I believe there still are none, so we will move on. Next is approval of the minutes. It was in your packets. Any comments or corrections? If not, I would entertain a motion. Move approval from Dorothy? Second? Okay. All those in favor, say aye. Aye. Any opposed? Okay, minutes are approved. Next will be our quality reports and updates not requiring committee action. The first will be the Dr. Charles E. Weber Jr. Golden Mitt Award presentations. Dr. Miller, welcome.
Thank you, Chairman Simmons. Thank you for inviting me. Hopefully we have representatives of the three areas that received the Charles Weber Golden Mitt Award for November, December, and January. It's my pleasure that we announce the recipient of the November Dr. Weber Golden Mitt Award goes to the Emergency Department. They were nominated by Labor and Delivery, and let me share some of the reasons this group of amazing professionals was nominated. First, they created a collaborative model and developed algorithms which identify and provide guidance for rapid disposition of the appropriate location, especially for labor and delivery patients. The ED has excellent assessment skills paired with efficient communication with the OB team that resulted in continued improvement of the care of our maternal patients. They've developed multidisciplinary interdepartmental drills to improve communication and handling of the OB emergencies. So this has culminated in improved outcomes for both mom and baby for a laboring patient presenting to the ED. Here's a great example. The ED treated a multigravida patient that presented to the emergency department at a preterm gestation with no prenatal care. The patient was complaining of contractions and leaking of fluid, and the ED provider rapidly assessed the patient and found her to have a prolapsed cord. The ED team immediately elevated the presenting part of the cord while simultaneously communicating with the OB team and transporting the patient to L&D. Once the patient arrived in L&D, she had a precipitous vaginal delivery with a breech fetal presentation. Because of the quick recognition and action taken by the ED team, this patient was able to deliver the healthy baby in a controlled environment, especially given the presentation. Had the ED team not responded urgently and effectively to this situation, a poor outcome would have been likely. Instead, their actions allowed a very favorable outcome for both the baby and the mom. So November's winner is the ED department. Congratulations.
Congratulations.
Emergency Department Manager.
Thank you guys very much. And like you stated, I think it takes a team, and it's great collaboration between us and OB. So thank you guys.
Thank you.
Thank you for all you
Congratulations.
do. Okay, the December recipient of Dr. Charles E. Weber Golden Mitt Award goes to our surgical specialty community health clinic. They were nominated by the Community Health Leadership, and here are some of the reasons this group of amazing professionals are nominated. Just want to let you know that I work both in the ED and in this clinic. They're wonderful people. The ongoing teamwork between both the practice managers and all the RN teams leads to improved turnaround times, especially for in-basket messages. They created a new business pool for each clinic and educated all the staff on this new pool names for each clinic. This team has showed significant improvement in the reduction of in-basket messages and the organizations of their IFUs and cleaning of their equipment, in which they have created tip sheets. In every survey, they have been recognized for their process as being best practice. It is through these efforts then that this great team of surgical specialty community health clinic providers is why they were nominated. Congratulations to you all.
This is Cheryl Edwards on wheels. She's our fearless leader. And we have Caitlin, Laura, and Leslie Ray. And what's exciting is I'll be presenting, and these are the people when we come up to present about quality initiatives as it relates to access and patient experience that are doing this work. And so, thank you very much.
Thank you guys so much.
Thank you.
And finally, I'd like to announce the recipient of January's 2023's Dr. Weber Golden Mid Award goes to our neonatal intensive care unit. They were nominated by the Maternal Levels of Care Coordinator, and here's just a few of the reasons this amazing group of professionals was nominated. The Neonatal Intensive Care Unit earlier this year established a new workflow that aimed to provide transitional newborn care at the bedside to keep the mom and the baby together rather than separating the mom and baby to go to the NICU. The first portion of the project included mothers with chorioamnitis, an inflammation and infection of the amniotic lining. Previously, all infants who received an antibiotic order when the mother was diagnosed with chorio, and with the transitional care, they are now able to significantly reduce the number of unnecessary antibiotics ordered by providing close monitoring of the infant in this transitional care area. Also, within the last year, an extremely low birth weight skin task force was formed to improve outcomes for infants by using a multidisciplinary team based on quality improvement approaches. And through this multidisciplinary collaborative, a small baby guideline was developed and established to perform uniform care and optimized evidence-based medicine for the care of this unique population. Ultimately, this task force has improved skin care, improved neurodevelopmental outcomes, and brought a newly developed SWAT wound care team to the NICU. In general, as I know, I've been in there several times, the NICU is always engaged and not only promotes the best outcome for the babies, but has a huge focus on family-centered care. There are multiple different task forces that address all the areas of infant care, including chronic lung disease, neonatal abstinence syndrome, necrotizing enterocolitis, deliveries, and mini milestone committees. And it's through all of these amazing efforts with this amazing team that the NICU was nominated for the January award. Congratulations to you all.
Congratulations.
Hello, everyone. I'm Crystal Gandhi. I serve as Assistant Chief Nursing Officer for this amazing team. I want to introduce you to Beth, our Assistant Manager for NICU.
The one that's not in the head.
I was having noticed you trying to pull the light. And this is Raquel, our NICU Manager. And this is Pam Gutseling, our Executive Director. So congratulations.
Congratulations. Thank you, Chairman. Appreciate it.
Thank you. Okay, next item on the agenda, moving down to True North, our patients, outpatient care management, connected care and engagement program. Welcome.
Welcome. Thank you. Good afternoon. I feel like I'm here just kind of as an extra, that Devin's really the star of the show and wants to tell you about our Connected Care and Engagement program. But a little bit about Devin. Devin's been at JPS for about 9 years and has led our care management department since that time. She's a true asset to JPS and our community. She was recently, last week, nominated and won DFW Great 100 Nurse representing JPS, so a true asset and star here at JPS. She leads many impactful programs for our patient population. Most recently and most notably is our COVID home monitoring program, which allowed us to take care of patients in their home versus here in the hospital. But we're here to share with you a new program that we kicked off about 1.5 years ago or so to look at our patients who are newly enrolled into JPS Connection and how better we can help navigate them from the very beginning. Devin. Clicker.
All righty. Thank you. Pleasure being here today. So our Connected Care and Engagement program actually started about October 2021. So I'm going to give you kind of some high-level information and then some real kind of details around some of the great things that we've been able to accomplish. So our plan, so we identified that there was a problem, not plan. One of the problems that we identified was that there was not structured care coordination for our JPS Connection members. And so we really wanted to meet with them and provide them some structured care coordination and education around their health benefits utilizing JPS Connection and the JPS Medical Home. So our scope, so we really wanted to make sure that we targeted a goal. And so we wanted to increase the percentage of newly certified JPS Connection members with one of several chronic conditions to complete a PCP appointment within 30 days. And so we selected these chronic conditions because we know if they are not managed, they could lead to avoidable ED visits or hospitalizations. And so as these patients are coming into our network, we want to make sure that we're connecting with them, screening them, and getting them to the right level of care at the right time. So our stakeholders, the Outpatient Care Management Department, eligibility and enrollment, primary care, community health, and our patients and families. Outcomes monitored. So we were monitoring and are still monitoring the completed CCE onboarding appointments, completed PCP appointments within 30 days of JPS Connection enrollment, MyChart enrollments, the social determinants of health screenings and the needs identified, and the overall completed outreach encounters. Processes monitored. So our quality and customer service of onboarding appointments, the brokering of those community-based resources as a result of those SDOH screenings, follow-up and interventions provided, and the number of patients enrolled in JPS Connection daily. So we really wanted to make sure that we are providing high-impact care coordination that's really grounded in clinical and social care interventions. What did we do differently? So we had to create this program. So we developed and implemented this new CCE program. Like I said, that it actually launched in October of 2021. We onboarded 6 new staff members, and so we really wanted to be intentional and take a look at our population and make sure that we were hiring people that understand our population and have a real grassroots connection with that population as well. So as a result, we do have team members that are bilingual. They speak Spanish, Nepali, Arabic. We are still trying to find a Vietnamese speaking team member because we know that those are our top languages here at JPS, is the Arabic speaking, Vietnamese, and Spanish. So we really want to make sure that our population feels like they're able to connect with someone who truly understands them. Design and production of our Welcome to JPS Connection booklet that I have here that I'm going to be passing around for you all to see, and we have that available in multiple languages as well, and a patient-facing community resource guide. A lot of times we connect the patient to resources by giving them a referral or a phone number, but we wanted to make sure that we crafted something that was specific that we can give to them that is truly patient-facing. The When and Where to Seek Care tool that is actually in this booklet as well, but it is a graphic that explains to our patients what level of care they should seek. So primary care, urgent care, or going to the ED. So we really want to make sure that they understand what right-sized care means, and then there are some dollar signs there for them as well so they can see how that affects their pocketbook. And then in connection and partnership with the JPS Foundation, we were able to have a Welcome to JPS swag bag. So in that bag, we have branded JPS t-shirts, we have some water bottles, some pens, just some fun ways for them to get connected to JPS as an enterprise. And then we conduct in-person or virtual CCE appointments and navigation appointments to discuss the JPS Connection benefits in depth, and then also navigating and coordinating those PCP appointments. We're also identifying if those patients need additional care management. So we have a number of outpatient care management programs. So at the time our team is screening these patients, if they see that there are some additional needs that they have, then they can connect them to a member of our team in one of our programs as well. And what was the outcome? So increased PCP appointment completions, that was our goal, and we were able to accomplish that. And then greater awareness and understanding of JPS Connection benefits and the services that we provide here at JPS. And we've gotten really good feedback and response from our patients and the families. So we have had a lot of patients who have shared that they knew that they had access to see their providers here, but had no idea how important the medical home is or all of the benefits that come along with JPS Connection. So they have been very pleased. So we know that there has often been a stigma around public hospital and safety net care. And so we want to make sure that our patients understand that although we may reference JPS Connection as a payer of last resort, they are highly valued members here at JPS. And so we really take the time to make sure that they understand the value that is JPS Connection, so they don't feel like they need to seek high quality care somewhere else. We offer that same equitable quality of care here at JPS. Study. So we were able to take a look at all of the onboarding appointments that were completed from the time we started in October 2021 through December 2021. And so we were able to have 5,721 appointments completed. Now, we would love to say that there were many more that were completed, and we're still working on that. But our team does a phenomenal job of reaching out to the patients and reminding them of their appointment, and then providing that transportation support if needed. If that's a barrier to our patients getting to their appointments, then we're able to provide transportation vouchers to assist them there. PCP appointment baseline data in 2021, that was 31.93%. We were able to raise that to 43% of the number of patients who were able to complete their appointment within 30 days of JPS Connection enrollment if they had a chronic disease. So significant increase there, and we're working every day to bring that number up as well. MyChart activation. So one of the things that we talk about during our onboarding appointments is really about how important MyChart is. So our patients don't have to pick up the phone and call our Access Resource Center and leave a message to get assistance. There are so many resources and things that are available within MyChart. We really aim to get our patients onboarded with MyChart. So happy to report that we've had 80% of our patients allow our CCE team to complete that actual enrollment in MyChart. There's about 700 patients who we still have a pending link out there for them to complete their enrollment, and then just a small number, about 65 people declined MyChart enrollment, and some of that is just due to their preference. You know, they may not use that technology, and that may just not be an interest at that time. And then our social determinant of health screening needs by domain. 70% of our patients have a transportation need. About 48% of them, food insecurity, 46% housing, and then about 24% of our patients experience financial resource strain. And so these are our top needs, which is really consistent with other organizations around the country. So what we do is we identify what that need is, and we connect that patient to a resource. And here's just a little snippet of the community resource guide that I referenced before, but it is patient-facing, and so we are able to hand that community resource guide to our patients. We're able to email that as well, and we are also working on seeing how we can get this in a QR code as well to have disseminated to our patients throughout the enterprise as well. Our outreach efforts. So although we had 5,721 patients complete the actual onboarding appointments with our team, we have about 21,000 outreach encounters in total. So that means our team is making first time, second time, third time attempts to try to connect with patients. And so that is a lot of our onboarding appointments and attempts are in person. We do virtual visits, we do phone visits, we do mailed outreach to our patients, as well as the My Message Hub that we use as a text messaging platform to be able to connect with our patients as well. How will we hardwire the changes? So we provide consistent coaching, training, and feedback to our team, constant meetings and feedback. We are very open to our feedback and open to feedback from the team and very connected to them as well. And so we have a plan to enhance our technology too, so we can have more automation and dashboard development to track the KPIs. And then ongoing collaboration with community health and acclaim for appointment access. And all of the leaders on my team. So Kendra Hasty is our awesome manager for outpatient case management. And so she is directly responsible for managing the team. And then we have our team leads as well and the CCE team members. So we are all responsible for maintaining the gain and the productivity of this program. So what are we going to put in place to ensure ongoing monitoring? So the weekly meetings and then utilizing the weekly and monthly operation reports and reviewing and monitoring the data and sharing it with the stakeholders. So we have really strong relationships and partnerships with community health. So as we are noticing any bottlenecks or anything, then we reach out to them and share what's going on, and then we work together to make sure we can find a resolution. Any questions?
I have a couple of questions. I'm all in. Thank you so much. This is so helpful, and thank you for all your work in providing the information and getting individuals back on track. A couple of things that I was looking at is in utilizing the community resource guide, are there warm hands-offs, or it's just a, here's your community resource packet, go forth and
So, no, there's not. So there's both, right? We give the community resource guide, but we are also making the connection to that actual resource to the patient as well. We do want to make sure that we respect dignity for our patients, and so we know that, oftentimes our patients may not divulge everything that they're experiencing, and so we want to make sure that we're arming them with the information so they can go and follow through at another time if they don't feel comfortable connecting with our team. But no, we are not just giving it to them and expecting them to navigate themselves.
And also, are y'all tracking the referrals once they go out to another organization coming back to us?
So we don't have a way to do closed loop, but yes, we can track the referrals to see who we're referring to as far as community-based partners go, and also that actual need. Yes.
Yeah, okay, perfect. Loving the idea of a little welcome packet, but maybe we can put in some health supplies there too, Band-Aids or something, because I know that's always a need as well that individuals use. Yeah, it's kind of like when you go to the health fair, I pick up all my sanitizer and my Band-Aids, and that lasts me for about a year.
So that is exactly what we do have hand sanitizer. We have a pill box for them as well. We have little stress balls. So we have quite a few things in there, and it's JPS branded as well.
Awesome. With on the next page of the completed onboarding appointments, you're doing transportation vouchers?
Yes, we do.
Awesome.
Yes.
Are y'all tracking where they're ending up, where they're they're going?
So we do, we have a global report. So yeah, we can get that information kind of teased out. But yes, we do have a global report for
Or you
transportation
could
vouchers.
possibly go back to the cities and ask them, hey, your patients are coming from here, you need to pay for this transportation also.
Yes,
So, yeah.
so we do have a report that we're working on and kind of teasing out where the patients coming from and where are they going. So we know that they're coming here to JPS, but what areas do they live in for that exact reason?
Perfect, yes. Y'all are doing amazing, that's great. On the MyChart activations, when you're saying that they're active, is this meaning that they've just got on one time, or are y'all tracking additional times that the individual has logged on?
So we have not tracked that. I do know that they are active on MyChart.
On MyChart, yeah. So sometimes the scheduling system on MyChart, it takes a while for people to respond. I know there's a disclaimer on there that said that it would take time to get back, but they have been taking a long time to get back on those. So, because it's not just a simple, hey, here's my availability, let me schedule. It's like, hey, I need an appointment here, and then it goes back a couple of times, back and forth. So that might be something to look at. Who actually is active on it, rather than I open my MyChart account. And when they open the MyChart account, are they activating their push notifications also, to where those messages are getting a push out from there?
So that is part of the process for our team when they onboard them, yes, because they are doing that with the patient one-to-one.
Cool. All right. I think last couple of questions. Okay. On determining the social determinants of health by domain, how are you surveying the information from your patients that that 71 are impacted by transportation? Is it a survey that they're taking, a questionnaire that they're filling out?
So it is a questionnaire that is embedded within our EMR, and so our team is asking the questions directly to that patient. Yes, and it is being recorded. We track.
Perfect. Okay, great. That's all I've got. Thank y'all so much.
And that SDOH screening is actually being completed in community health as well. So in partnership with Joy's team, as the patients are coming into their clinic appointment, those screenings are being asked. It's embedded in Epic, and so we do have some logic built in. So if patients have some identified needs right now, then we have a referral built that it will send an Epic referral to the outpatient case management social worker work queue, and then we complete outreach to the patient to make sure that we connect them to the resources that they need.
Are we not extending that to inpatient also? Is that not part of the work that we also do that?
Yes.
Survey
yes.
the time the inpatient
Yes,
too?
January 16th is when that went live for the hospital.
Oh, wow. Okay,
Yes,
good.
and that is occurring. So we are working on building the reports for that as well.
Okay. So, quick question. Where you're looking at completed onboarding appointments, we've had a pretty significant fall off in the fourth quarter of 2022. I was just wondering if you had any insight on that. And oh, by the way, I meant to say, congratulations on your recognition. That's
Thank you, Dr.
fantastic,
Miles.
Devin. But help me understand why it fell off.
So we believe that because of the holidays, if you look at 2021, that you have a lot of patients who did not follow through with keeping their appointments during the Thanksgiving and Christmas time. That's usually what we see around that time of year, that patients kind of back off a little bit more. We have not backed off, though, in the outreach attempts that we do with our patients. But for some reason, we just often cannot get them to follow through.
So you think it's a holiday halo effect?
I do.
Have we seen that holiday halo effect previously? I'm trying to look this October, November, December.
So yes, in 2021, if you'll look there, you'll see the lower numbers as well.
A little bit of a fall off. Okay. And then, Devin, my other question is, are there any comparative benchmarks out there for this kind of work? Because this is great work, but we're only comparing ourselves to ourselves.
Not that we are aware of, no, which is why we thought that this was so important.
Does Parkland have anything that they track that we're aware of?
Not that I'm aware of, and I do have some connections at Parkland, but no, I'm not aware that they have a similar program.
I'd like to say thank you. It's been a long time coming, but glad that it started. On the 30 days for the appointment, are those the ones that are identified in the ER or here that you make sure that they are having a situation? I'm just trying to figure out how you come to how we get 30 days, because that's a real quick number for.
So it is. And so the report that we receive comes directly from eligibility and enrollment. So this is patients that get certified with JPS Connection from all care sites. So it could be while they're here in the hospital, or it could be at it could be at the eligibility main center or one of our community clinics as well. And so after we get that report, then we're able to screen the patient and look at their chronic conditions. And so once we realize that they have one of those chronic conditions that were listed, then we work to get them an appointment within 30 days of their initial connection enrollment date.
Oh, okay, all right. I think that's a very aggressive short term, because I know that usually it's 45 days for you to get that first appointment, if not 60 for a full-time visit. But if you're having problems, they do get you in. So I just commend y'all on that 30 days. Okay.
We want to be as proactive as possible to make sure that we don't have these patients going to the ED or end up, hospitalized at day 40 or day 45. We want to catch them as early as possible to get them connected to care.
I commend you for that. I know that's the difficult. Now, after we put this program in place, have you shown a decrease in your no-show ratio for patients that you are contacting to see those PCPs?
So I can't say that we've actually tracked that specific metric from our baseline data. But in looking at the baseline data, you can see that the numbers of completed appointments actually did increase. So I would like to believe that we've made a significant impact there.
Okay. Well, I would ask that you look at that, because your numbers might be increasing because you're adding new patients, but your follow-up from some of the others that you are contacted maybe are not showing up. So between both programs, no-show should show a reduction for your 30 days, and those that you check on at 60 or whatever, that should be one of those. But I think that you're in the right vein, and I'm very glad to see that we are giving our patients something.
Thank you. And we can start tracking that.
Okay.
I was curious, because you said that the JPS Connections patients can come from inpatient visits as well as them coming through the community. And I know that especially for inpatient visits, there's always that priority to be seen kind of within the transition care management. Is that factored in, or is this in addition to those kind of 7-day follow-ups to establish primary care after a hospitalization?
In which regard? Because if they get their appointment when they're discharged from the hospital within 30 days, they're still going to come on our radar, and we still want to complete an onboarding appointment, right?
Yeah.
So we check the box there that they got a scheduled appointment, and we can provide the transportation, but we don't want to miss the opportunity to really talk about the benefits of JPS Connection, the benefits of the medical home, and do that SDOH screening too. So we're not going to not take the time to complete an onboarding patient appointment with those patients.
Okay, so they get both.
Yes.
And then, I was just kind of curious, because what Dorothy was saying about, 30 days is very aggressive, and, just the ability to get access to the primary care doctors within that time is difficult. And so are these patients prioritized? Are there set aside, appointments for them to fill, or how do you get them in so quickly with the PCP?
So yes, so we did partner with Community Health to prioritize these specific patients. And yes, there are, some times where we do have some barriers as far as access goes when you have weather events, or, you have PTO or, holiday time. But we have a really good relationship with Community Health to be able to do some finagling and working together to make sure that we can still meet the needs of our patients.
Devin, do you know about how many per month that fit this criteria of chronic disease? Because that's right, it's that subset, right?
With a 30-day appointment.
That have, yeah.
Correct.
A little bit higher mortality. Do you know about how many of those that each month that actually meet this criteria that you are scheduling now to be seen within 30 days? That may give us some.
Let me follow up with you on that, Dr. Duncan.
On how many you're really talking about.
I can get that
Not every single
information.
patient on JPS Connection, but just those who meet
Correct.
that criteria.
Yeah. Correct.
Because some may need a follow-up in 6 months, right? They're otherwise healthy and well, and, their follow-up, definitely, it's not necessary for it to be within 30 days.
Correct. And we're still scheduling that appointment for them for the next available.
And the only other thing I see going forward is just, the number of scheduled visits versus the number completed with the PCP appointments. It'd be nice to see that number kind of even out a little bit. And so, just ways to outreach these patients to remind them of their appointment, to make sure they have the transportation.
And we're providing the transportation vouchers. We're reminding, we have 21,000 outreach encounters. They are seriously, calling patients, texting, MyChart messaging to remind them. So we're really trying to figure out what else we could possibly do to bring that number up.
Oh, I know it's not easy, so I appreciate all those efforts.
I just want one more caution as we are doing the 30 days to primary care. It is important that the patient actually see their primary care doctor and not be appointed to a doctor just to see them to get into that 30 days. So I think on the 30 days, if it's a small number, that
it is.
That would be great, but I know that the primary care doctors are not able to follow up on their patient, and they are seeing a different doctor. That's not the outcome that we would want. So just be aware of that, okay? Okay.
I'm the one that least question today, but question for you is, because we're dealing with the very, very different type of eligibility, right? Because they in and out, just like Medicaid. How do we ensure that we have continuum of care, and then also, if they fall in and out, are we replicating the same thing?
No, we are looking at the net new JPS connection members. So that means if they have not had connection for at least a year, right? Then we would say, hey, this is a new patient. We want to meet with them and explain to them what the connection benefits are. But as time goes on, I think we would recognize and say, hey, we've already completed an onboarding appointment with this patient, even if there was a lapse in JPS connection coverage. So we're not duplicating those efforts as well. So no, we're making sure that we're focusing on the JPS connection and cares members that have this payer as primary and not secondary, but also that they are considered a net new patient and not someone who is recertifying.
Will we be able to tell if they're falling in and out of our program? For instance, they have us, and then they have insurance, they go to another facility, and then they come back to us when they don't have it, so that we can see and predict down the road to see what type of population that we're dealing with?
I'm not sure I understand the question.
Because they fall in and out of the program, right? These are not, it's not like workers' comp or Medicare, where when you hit a certain age or a certain problem, you insure for life, right? So they're in and out. I'm trying to figure it out to see how often do they fall in and out, and then do they stay with us, or do they go to a different facility where they have insurance and then they come back to us for continuity of care?
Okay, you're saying if we have a JPS connection that we have certified, and they've marched along with us for 8 months, they drop off, then we see them again in month 13. Do we ask any kind of questions to find out if they had insurance or what happened that they end up coming back? I don't know if our eligibility is for a year or 6 months. One time it was for 6 months, and I think they've extended it to a year now?
12 months.
12 months, okay.
So, right, I'm not certain if eligibility and enrollment tracks that information. That's not something that outpatient case management tracks, but that may be something that eligibility may track.
Because if we give them 12 months and then 3 months they found a job, we continue to pick up the cost, but it's supposed to be somebody else's cost too. I'm just trying to look from a financial standpoint. And then the other side of it, I'm trying to look for to see if they fall in and out program, because the commercial side, right, the third-party insurance side, it's very hard because we want to move into wellness program and everything else, but no employee is going to do front-loaded because the loyalty is not there from a employee perspective. So why front-load everything and then they go work for somebody else and you pick up all that stuff? and we're trying to see is there any variation here so that we can make sure that as we front load everything and be very active with our population, it is the right thing, and we know if they don't, because if they, let's say they have insurance and they say, oh, I have insurance, I'm going to go to THR, and then the next time they go to us. So we know that they're not really a loyal patient that will be in and out, so we can figure out a different way to treat them down the road. So we're too early, so I'm just throwing stuff out so that we can look at some of the possibility that we're dealing with.
Yeah, I don't think it's something we've tracked in the past, but we definitely can take a look at that. I don't know how often people are moving in and out of the programs.
Because it's nice to have 12
Right.
months or 6 month or 12-month eligibility, but for those that fall in and out,
Right.
we front load something that we're not the last resort.
Thank you.
All right, any other questions? Congratulations, Devin, on your award.
Thank you. I'm going to
job.
leave these booklets here for you all as well.
All right, next item on our agenda, behavioral health, depression remission. Welcome. Good afternoon.
Happy Monday. Well, I'm excited to share with you all the great work that a lot of folks have been doing with regards to depression remission. Let me see if I can do this right. Okay, we got that. So our team was multidisciplinary, but our primary team members were Brenda Gomez, Tanisha Kennard, myself, Joy Parker from Community Health, Dr. Alan Pottawiltz, who's chair of our Department of Psychiatry, and Dr. Alawi as well from Community Health and Acclaim. So our problem statement, JPS Health Network identified a need for an integrated approach to managing depression for our patients. 80% of individuals completing suicide actually had contact with a primary care office within the year prior to their suicide. Our scope was to increase the percentage of JPS connection patients who achieve significant improvement in their depression within 12 months of their initial positive depression screening using the PHQ-9 depression screening tool, and that's a evidence-based standard of care screening tool that's done mostly in outpatient behavioral and ambulatory care clinics. The stakeholders were behavioral health, primary care, community health, our patients, and their families. Sorry, I'm trying to multitask. Outcomes monitored. So for our JPS connection patients aged 18 and older with a diagnosis of major depression or dysthymia and an initial PHQ-9 depression screening score greater than 9, who demonstrate significant improvement at 12 months, defined as a PHQ-9 screening score less than 5. This measure applies to both patients with newly diagnosed and existing depression whose current PHQ-9 screening score indicates a need for treatment. Our processes that we monitored ongoing PHQ-9 scores, follow-up interventions with interventions provided, utilization of the psych emergency department and our medical emergency department. So what did we do differently? We continued, because we did start this in 2021, so we continued in 2022 with depression screening at our outpatient clinic appointments, so that includes community health as well as behavioral health. We coordinated with a team of transition coordinators who were responsible for follow-up with the patients through this 12-month period. And so that's 5 individuals that are master's level social workers or licensed professional counselors that are providing this follow-up care with our connection patients who score positive. We also had resources through our foundation to assist patients whose symptoms were impacted by social determinants of health, such as food access, paying bills, transportation, medication costs. And the other thing that is not up here but is equally as important, we had a pharmacy platform. So our doctors who were writing orders for antidepressants or other psychiatric medications, primary care and behavioral, it was a Power BI platform, and they were able to go in and look up their patient as well as the transition coordinators to see if the patient picked up the medication that they were prescribed, and it's in real time. And so our transition coordinators would get notification within the EMR that the patient hadn't picked up their prescriptions. So then they would call the patient and say, what's going on? Can you tell me why you're not getting your prescription? Are you having too many side effects? Can you not get to pick it up? Can you afford it? Those type of things. And so that was a lot of hard work, but it was eliminating a major barrier to them achieving significant improvement with their depression. It was a huge win. The doctors loved it as well because they were able to know who's taking their prescriptions and they're getting their prescriptions. What was the effect of our actions? Depression remission for JPS connection patients for the fiscal year 2022 was at 34.36%. So 34.36% of our JPS connection patients that were identified went into remission, which was less than 5 on the PHQ-9. The other thing that I really want to point out that I think is equally as impressive is that 58.94% of the other patients, they had a PHQ-9 score of 16.44, and they achieved major reductions in their depression symptoms as well to an average PHQ-9 score of 6.75. So not only did we have almost 35% have a total remission, but we had another 58% have a significant reduction in their depression screenings and their depression symptoms. The transition of care team was able to directly collaborate with providers in community health clinics. This response was overwhelmingly positive because a lot of the patients that were experiencing significant depression were just really struggling navigating community health clinics, navigating primary care appointments or the pain clinic or whatever. And so in many instances, the care coordinators were doing that for these patients. And so the response was overwhelming. There was a huge increase in the collaboration, and it continues now as I speak, between providers and the care teams, between primary and behavioral health, which is something that I think this organization needs to be proud of because that does not happen everywhere. And our providers have really taken the lead on that, as well as Joy and her team. After completion of the care management services, some of the patients still continue to call, even though they're not necessarily officially in the program. They're still in. And so we still do what we can to help those patients. Here's a graph just to give you an idea of where we started in FY20 here at JPS. Our baseline was 8.09% of patients in remission. In our first year of implementation, we were at 25.29% in FY21. And in FY22, 34.36%, as I stated. In FY21, we were in the 90th percentile nationally. In FY21, also the national rates dropped to 22%, so we were well above some of the national rates, which was exciting. FY22, there was no new data because CMS halted mandatory reporting during the height of the pandemic. And so, but based on the previous data, we're still within the 85th and 90th percentile.
Be 100%.
Some of the other things that we were measuring as well were decrease in the number of visits to the ED and also the psych emergency center. In FY21, there was almost a 23% decrease in medical ED visits by this group of patients that we were monitoring, and almost a 23% decrease in the number of the psych ED visits as well. And same for behavioral. And FY22, again, continued reductions in medical and psych ED visits. And then for those individuals that were in remission, FY21, we saw almost a 17% decrease in medical ED usage, almost a 34% decrease in our psych ED. And then in FY22, we had lower numbers because their utilization was lower, but still a reduction in both medical and psych ED visits. There's, as I said, I may not have said yet, but we did get some money from the foundation to assist us with our patients, to help them with their social determinants of health. And so here's a little bit of data from just this fiscal year. The top things that were impacting our patients, navigating of the JPS service, telephonic therapeutic support they found very beneficial, navigation of other community resources, general assistance with medication, vouchers, transportation. We did assist 176 individuals with medication, utilities, rent, as well as transportation. And next steps, we'll be leveraging this care coordination model to other disease-specific models, because the care coordination piece does work, and that's whether it's depression or some other medical comorbidity. We think that's a good framework to build going forward. So for us, how are we hardwiring this? We have weekly and monthly reporting meetings, and we have weekly and monthly reporting. Of course, we have this whole program on Power BI where we can monitor it any second we want as well. Then we have monthly team meetings, and then we also, the providers, the clinicians, support staff, we're all accountable for maintaining the gain. And to ensure this occurs, we still have the operational reports that include pharmacy, PHQ-9 scores, as well as social determinants of health are being monitored, shared, reviewed, and discussed. Thank you, everybody, and I will open it up if anyone has any questions, but this has been an exciting thing to be a part of.
I'm curious, how many touches after the PHQ-9 was initially documented and treatment started, how many touches by the coordinators with the patients? How frequent? How many?
Multiple touches. And initially, it was every 2 weeks in the beginning, because it was just multifaceted, the interventions that were needed, whether it was medication, transportation, rent, utilities, because they weren't able to even address their depression until we could get that under control, and assist them to take away those stressors. So initially every couple of weeks, but then they also had our phone numbers as well. So it was a bi-directional communication also. And then every 3 months we would reassess their PHQ-9 scores on top of that. And then ask them, what can we do to help you get to a better place, those type of things. And so the contact was ongoing throughout the entire 12 months and beyond for most.
But who primarily is the one that's making contact with the patient? Are they social workers or?
Yeah, so we have 5 transition coordinators. That's what we call them in behavioral health. So those individuals are strictly for this program. And so it's a combination of MSW social workers as well as LPC level Masters of Counseling.
What clinics do the screening? Is it?
All of the outpatient clinics and community health do, as well as all of our outpatient behavioral health clinics.
How do this mesh with MHMR? Are they a part of any, we keep all the patients and we're not referring anybody to MHMR?
So for those patients that are already connected with MHMR, they will remain connected with MHMR. However, for those patients that are not connected with MHMR or may choose not to want to return to MHMR, they come to our clinics, and as well as they're already engaged with our primary care clinics. So it really makes for a better continuity of care to be at a behavioral health clinic here as well.
Okay. So if a patient is with MHMR, they have the opportunity to transfer?
Yes, ma'am.
Oh, okay.
Or they have an opportunity to remain with MHMR. It's the patient's choice.
Okay. All right. Thank you.
And then just as far as eligibility goes, any patient with an elevated PHQ-9 score, it doesn't matter which clinic, they would automatically be enrolled in this program?
Yes, ma'am, as long as it was a JPS connection patient.
Okay. And was it the PCPs who identify, or is it something just through Epic you were able to track?
It's through Epic.
Yeah. I mean, that's really neat.
The 2% for transportation medical voucher seems low, but then when I look at the current 2022 data for June, and we are halfway in 23, so is this what we may see going forward, or is this still lingering from the COVID time?
I think it's still lingering from the COVID time, but also anticipate that our patient pool is going to expand even more as well.
I saw the 2% pretty low there.
Yeah.
A follow-up question to that, then, how many of these are telehealth visits where transportation would not come into play?
So a lot of these visits are telephonic, but if they need transportation to go to a primary care appointment or a behavioral health appointment or to get medications, then yes, that is provided.
So are you anticipating that your telehealth numbers will continue to go up, right? Yeah, that's what I thought.
I do.
Okay.
And it's actually easier for the patients. But now if they do need a face-to-face, obviously we're available to do that as well. But typically most individuals, if they're able to be in their home, they oftentimes prefer that.
Right. Okay.
Do you track the no-show rate, like live visits versus telehealth?
Well, most of it has been done versus telephone, and most of it is telephonic. And so the biggest challenge we've had for follow-up, and those numbers are tracked, but I don't have them in front of me, so I do apologize for that, is sometimes we don't have the right phone number for contact. And so that's a joint project that we're working on to make sure we're getting the data correctly in the EMR and those type of things. But that's gotten much better.
Are patients able to change that in the EMR themselves, their contact information?
Yeah. Yes, or the PARs and all the clinics are able to change that information, as well as the social workers, counselors, anybody can.
If they have my chart, they can change it themselves. If not, you'd have to get to a physician access representative.
Okay. It looked like from the prior presentation, about 98% of our patients either have used, pending use, or are using my chart from what the other graph looked like, which is pretty high.
They like it a lot.
I think on the other one is they made sure that they signed up to it, and that was one of Amanda's, after they signed up, how many of them was actually using it. I mean, it's a great tool. I mean, I'm trying to encourage everyone to use it, and especially if you call me, the first thing I ask, well, have you gone on my chart and looked at your information? And to the point that I might ask that we be allowed to do at some of my meetings in the community, that's a good place for me to walk them through my chart, so.
For the My Chart, I'm assuming that it has the capability for that delegated caregiver to access to it.
If you give them your password.
If you give them your password.
It's locked down with password protection. It's encrypted, and some My Charts, I don't know about ours, some My Charts you have to have a second authorization, sign on.
But if it's somebody that are not familiar with computer and stuff like that, that their daughter, their son, or their grandson, granddaughter may want to be the assigned delegated caregiver.
You can grant
Is that
permission. You can,
I think Colin would tell us it's okay if the patient grants access, you can.
access for a certain period of time. I know my sister will send her labs to me, and I have a certain period of time I can get in there and actually see the labs that were reported out that day. So, I mean, that
they allow it. They allow it.
Many health systems, I mean, pretty much have forced patients to use the electronic health record in order to communicate, to receive their labs. We've been a little soft with it here, but I mean, my mother's 90 years old. She can use it. So, I mean, I think that, and
Cleveland Clinic
she knows
is
how to push
charging.
it out.
Right.
Cleveland Clinic is charging for certain types of encounters that are occurring in My Chart.
Really?
Yes, ma'am.
We may,
Quite controversial, but depending on the level of interaction that a provider may have to provide relative to the My Chart message, they're associating a small charge to it. If it's, yes, so.
I know that.
revenue producing for finance.
I'm just throwing it out there. Cleveland Clinic's doing it.
I was just going to add before you, I think this is a very effective method of kind of, reaching to the patient. I think it really lends to the behavioral health arena very well because you can easily measure outcomes using the PHQ-9. So it'll be interesting using it to address other care conditions that are not so easily done virtually or telephonically, and then also there's not such easy benchmarks. So I look forward to seeing how y'all do that.
Thank you. Zelia, real quick before we let you go. Great presentation. Thank you. As always, you're very prepared. The pharmacy piece where I can go in and see if you picked up your script, is that just from JPS Pharmacy or is it linked through Care Everywhere to other pharmacies?
Gosh, you're going to tax my last brain cell. I think there is a link to Care Everywhere, but I know for sure it's Maxor. Okay.
It's just limited.
Just Maxor because.
So I could go pick up my Walgreens prescription and it'll look like I didn't pick it up in Epic, right? Okay.
Not within the integrated system that we have with the easier for them.
Okay. Thanks.
Any other questions? All right.
Well, thank you all.
Zelia.
Good report.
Okay, next, community health, access, and patient experience. Welcome.
All right, good afternoon. This is
Good afternoon.
a long day. They saved this for last, and I can strategically probably, but no. Good afternoon. I'm glad to be here today. I'm here to provide some updates around access. And when I say access, that is very broad and encompasses so many things. But this is very specific to the call center. And just for reference for those that might be new, we do have our Access Resource Center, which is our call center. That team is located out at South Campus. And of course, we do have virtual in this industry, having virtual call agents. This Access Resource Center, the scope of it is it covers primary specialty calls, nurse triage 24/7. We receive over 1.2 million calls a year. And our hours of operation for receiving those calls is 6:30 in the morning to 7:30 Monday through Friday, and 7 to 1 on Saturday. And then, of course, nurse triage is 24/7. So that team. So with that, I do want to give a lot of credit to those. As you saw, many team members were here today. As we go through this slide, Camille Charat, she's the executive director over our call center, and then Angela Ware, who helps to lead our quality internally within the community health. Appreciate their support and their team member support on this effort. So what is the problem? I'm sure if I turn my mic off, y'all would tell me exactly what the problem is, because I get your calls, okay? And so we understood that there's an opportunity. And I do want to make clear today, when you see this data, we know this is a journey, and we're not where we want to be yet. But we're moving, I think, in the right direction. And I do want to pause and definitely not pandering to the board, but to say thank you. When we had our budget meeting and we asked for dollars for certain things around technology, people, to support processes, you approved that. And that budget is super important. And I'm going to show you a little bit of how it's been making a difference, because we have definitely acted upon it within this fiscal year for this budget time. So we needed to make improvements for timely access and increase our patient experience at the contact center. And so that scope, again, there's many contact centers. Zelia, her team has a contact center, and some other different departments, so very specific to the Access Resource Center. Our stakeholders, first and foremost, are our patients, our leadership, our team members, which is inclusive of both our physicians and our staff. So what do we measure? How do we measure success? And so how we identified this, and this was, again, multidisciplinary team that we brought together in this last year, creating a network access steering committee, which is inclusive of physician champions, our leaders, engaging with our patient advisory group. But the metrics that we identified that was important to them was around our Press Ganey patient experience data points for ease of scheduling appointment and ease of contacting the clinic. From a call center, specifically, we look at average speed to answer, our average abandonment rate, our handle time, which gets to the quality of the call and that time duration. Our nurse triage, obviously very specific protocols that we align with our nursing and physician leadership to ensure that the standards for nurse triage is appropriate, so quality there, and as well as our call volume. And then also referrals. We love to talk about referrals, but a referral management team of how do we help to make sure, in partnering with Rory McCready and his team, and James Smith that oversees this at our call center, our referral authorizations to approve for specialty appointments. Those are the lagging metrics. The leading metrics that you see, again, is around the call handling, the management of employee call time, so making sure we have resources available to answer those calls, and then, of course, the quality component of it. So what did we do differently? We developed a network access steering committee, again, comprised across the JPS Health Network of our physician champions, as well as our leadership team, stakeholders, people that actually do this work, collaborated together. And we began this effort to identify a couple of different buckets that we would go through: clinically, business, technology, and communications. And so in all four of those areas, we identified opportunities and created subgroups that worked specifically and tactically to respond to that. So our first thing, I will tell you too, we had a PwC come in and do an assessment and report to help us identify industry best practices to assess our operation from front to back. And they developed that report. And from that report, we took what they said. So it's brought in what the consultant said, and we incorporated that into our Network Access Steering Committee. And they identified a couple of things, and we've created a project plan that has a pathway, and we're moving through that. Will Showalter, I know as he's transitioned on, we appreciate his support because it's a heavy IT lift and things that we're doing there. With the staffing, we reorganized our teams into more of a pod-like structure, so they become very specific and specialized to the different areas they were supporting. And again, this was a definite recommendation. increasing in staffing for call agents. Currently, our one call agent, one full-time agent receives over 30,000 calls annually. And so the typical industry standard is one call agent to 15,000 calls. And so the staffing is important. You got to have the people to answer the phone. But in addition to the staffing and staffing up referral authorization, our other goal was to also decrease the number of calls, right? We shouldn't be, in today's society, more people are doing everything automated, direct scheduling, all of those features. And so that was also a goal, is how do we actually decrease the volume coming into the call center so it's more in the hands of the patient that want to do that. We looked at schedule reviews with our regional medical directors and our medical directors in our medical homes, and you saw this with specialty clinics, but we looked and said, hey, let's look at your template, because access is more than picking up the phone and calling. On the back end, the physician needs to be available and their schedule needs to be available. And so we worked really hard to make sure we were maximizing the schedule templates. And then real-time flexing to peak call volume. If you go into our call center today, we have screens up much like this, and we have supervisors that are managing and looking at the call volumes and seeing where there's hold time, seeing where there's maybe an agent that might need some help or is stuck. And so they're real-time monitoring this and doing manually what we call workforce management solution. And so this is something that a new technology will do for us automated, but we do this manually now. We develop scorecards. So the scorecard is really around the effort of, if you get a call, did you really take care of that call? So we call it one call resolution. So if you call and we know you need to see your primary care doctor, but you also say, well, hey, I'm also want to check about my referral to my specialist. We measure and work with the call agents from a quality perspective to get to one call resolution so that they take care of all of the needs of the patient when they call, because it keeps us from having repeat calls back and forth. And in addition, we have a scorecard that on this scorecard is My Chart activation. Did we talk to you about My Chart? And then did we help you to get on it? So that's also incorporated in that quality component. And then with that, we reward and recognize when people are doing well with that. We also looked at volumes to see if we could get some support, so we contract with Relay Care, who helps to provide a little bit of overflow support, so it triggers when we hit a certain amount, they begin to pick up the phone. I'll tell you it's good, but it's been challenging, because knowing your internal team and the people that work with these doctors, when you outsource it, it is helping, but sometimes you have a little bit more issues, but we work with them and we meet with them regularly about their quality in providing service to us. And then, of course, back to the My Chart direct scheduling. So, Amanda, to your point, talking to Devin, it's how are we making sure that My Chart has availability for same-day follow-up appointments? We're kicking off this March to look at new patients, so that how can we do a direct schedule for a new patient that maybe doesn't have that My Chart number, but how do we make it easier for them to engage with us? And so that's definitely part of our effort, because, again, it helps us to give the power into the patient's hands and decreases the demand even on our own resources. So what was the effect of our actions? Well, again, we are not perfect. We are still going. But we did see improvement. And so improvement in our patient experience scores and improvement in our timely access metrics. So here you see here, again, looking our Network Access Steering Committee, we started this work really 2021, in a year when everything went, I think, the wrong way with nationally, and you heard previously our patient experience leadership speak of this, we actually progressed and moved forward. And actually what we saw was statistical significance of Press Ganey improvement was 1 to 2 points. We moved up close to 4 to 5 points there, and so we're excited about ease of scheduling. Is it where we want to be? No, but we're definitely moving in the right direction. Ease of contacting clinic, and I had a whole bunch of different graphs, but I wanted to highlight specialty because the team that was here that got this award, they really helped to just partner with our physicians and our staff in the specialty clinic appointments, talk to our patients, understand their pain points, and really drive this improvement, which this is, if you see 57.3 to 64, a huge jump there forward for ease of contacting the clinic. So this one here you have is the actual, it's a busy slide, ease of contacting the clinic. And I took a snapshot of some of the clinics that had kind of the highest improvement here, but our change over baseline points for certain departments, and you can see, 11 points is just, Press Ganey is asking us what we're doing here because it's just it's a big bump. But what happened here is you can see the clinical in-basket response times is the teams, when someone calls to speak to their clinic, we actually do an in-basket message, okay? And so it's like well, everyone's familiar with Epic in-basket, I think, but like an email, right? But we worked with our providers to mature the message, so we're getting the message to the right time, and when it gets to that provider, it has the information they need, so they can make a recommendation, so we can close the loop back with the patient. And you can see here that we've, on our average days of clinic in-basket response time back to that patient, we moved it from 5 days of an average time frame to less than a day over in ortho and podiatry. You can see in oral maxillofacial a big jump from 6.6 to 1 day. ENT to less than really the half day. But if you talk to this team, they can tell you really what they did with daily reports with the teams. They look at this daily in their huddles. They talk with the providers. They made sure to clean up to get the messages to the right people at the right time. But really the accountability, they're really on top of this. And I want to stop because, again, this is the Network Access Steering Committee. We had Dr. Henderson, Dr. Sloan, Cheryl Hull, Leslie Ray, Selena Garcia, Caitlin Dalgo, and Laura Lurie. And I say that because they're probably watching, because I told them to watch, because I wanted to say, team, we know, we hear the pain points. I know when Dorothy gives Dr. Duncan a call and then I get a call, because we still get the one-offs. When you have 1.2 million calls, you're going to have a call that didn't go exactly how you wanted it. But the important part is that we're going back to our team members. We're talking about that, we're learning from that, and then we're saying, how do we move forward so that doesn't happen again? It's very much around like that just culture methodology. So average speed to answer, primary care, I put this box here as well. We were at 48, to me, again, back to the journey, we were at 48 minutes average speed to answer. A lot of that, I really do contribute to the fact that we were able to staff up. Staffing was definitely a challenge, so people to answer the calls. And here you see 2022, big jump, thank you very much, again, on the staffing. And then 2023, we're at average at 8 minutes and 44 seconds. I'll tell you on the ICE day, I talked to Camille a lot real time about what are those metrics, the read time with the GNAV reports that we get, and it was less than 2 minutes. And we had 100% of our call center agents online during that ICE time. And so they were really dedicated to making sure we were on the phones to support those patients during that time frame. So still not perfect, but we're moving forward. So quality, again, I can get someone to pick up and make my average speed to answer look fabulous, right? But did they take care of the patient? And so this is where we sit down and there's a quality auditor that sits down and reviews the calls, talks to the team members, lets them listen to it, make sure that if they called and they wanted to speak in their specific language of preference, that happened with translation services, my chart, did they get their resolution? Did they call them by their name? All of the different industry best practices around a call center experience is what is being scored with these agents. And so this was something that we're really proud of. Daryl Gomez, who's our nurse manager of nurse triage, especially him for our nurses. He looks at those clinical quality calls to make sure it passes the clinical quality standards as outlined by those approved algorithms by our physician group. So back to the 4 buckets I was talking to you about with the Network Access Steering Committee, one of those being communications. We identified, as we were looking at the data, that approximately at the beginning of this, 60% of the calls of the 1.2 million were for calls that were not calling for a specialty or primary care appointment. They're calling for other things. Maybe they want to check on a loved one at the hospital. Maybe they were wanting to know about their insurance. Maybe they were wanting to know. Well, we realized really quickly that the information on external websites, so when you think about search engine optimization within technology for what's on Google Maps or what's on just different search engines that are out there, it had incorrect information. It had wrong hours of operation. And we saw that we needed to clean it up, including not only on external sites, but internal sites. so we could have the right information when someone goes to Google. And so what we've seen is a dramatic drop in that, I would say the waste of sending it to the 1100 number, but actually getting it to the right place so they get that access. And I want to thank Jessica Vernosh and her team because they did a big heavy lift on the internal information as well as externally working with those companies to get that information correct. So how will we hardwire these changes? We're continuing with the consistent monitoring of the data, the coaching, the training. I will tell you, Will, myself, and a large group, we're looking at different RFPs for technology platforms. And so our technology telecoms is from 1999. And so it's time. And so we are working, I'll tell you, this team, to know what they're working with to make the improvements they are with the age of the technology it is really pretty phenomenal. Not where we want to be, but we're going to get there. And so we're going through right now those RFPs for unified communication and software call management software programs. And I say that because you'll see me again soon, or will soon, hopefully, with that. So a plug for that. But we're hoping that this technology is really going to help and make it easier for our team members and also for our patients. And really, it's about our patients having an easier time. And I think, let's keep going. So again, recruiting and staffing, talked about helping us for the staffing piece of it with the budget. Thank you. Technology limitations, we do a lot of stuff in SharePoint very manually. And so we are looking at decision trees that are embedded. So when a call center agent sees your number pop up, it'll say, oh, this is Dr. Janet Miles. So it recognizes that. So it really makes it forefront to the call agent. And so makes it easier and embeds exactly what they're wanting to do. So it pops that up to get to them a lot quicker, so making it more efficient. And then I think the other challenge is always is, like from the book, Who Moved My Cheese, right? Or Don't Move My Cheese, whatever it is. No one wants their cheese moved. I don't know. But, it talks about people don't like change. And so we really had to have frequent touch bases with the team and say, hey, we're going to try something new. This is what we understand might be a best practice, but at the end of the day, it's for our patients. So work with us here on that, but also reward the performance of those who are willing to be agile enough to do that. I do want to say, as staffing, as we're trying to find great people to come work at JPS, we developed a partnership with Texas Workforce Commission, who I was driving by one day and we saw that they office right by us. And so Camille and that team, in partnership with HR, we went around and we actually have had a couple of successful hires from a paid 13-week program where Texas Workforce actually pays for that trial, and then if that works out, then we retain them at JPS. And so we're helping people who are local who need jobs to get jobs. And so that's another side thing that we've been really proud of, and trying to look for creative solutions to answer the issues around staffing. So other than that, I'll close with that as my presentation, and I'm happy to answer any questions.
Are the call center agents all on campus, or any of them working remotely?
So when they are remote, there's remote and on site. What we do, because space is a limitation for sure, and so, but the industry standard is that call centers are remote, and so we wanted to be competitive with that market. The way it works is they come for an intensive onboarding and training program, and then if they maintain a certain quality score, they're allowed to work remotely. If they don't, if their scores dip below a certain percentage on their scorecards, they're required to come back on campus.
Is that working from home? Are they able to do that?
Yes, and we're able to remotely monitor. So we can see, back to the lead boards that I tell you about are in the call center. I can see that, sorry, Dr. Miles, Janet's on, and her phone is on, and I can see how many calls she's taken, what her average hold time's been. So we can monitor if she's assigned a line, how productive she is. And productivity is one of the scorecard analysis for our quality scorecard.
What kind of software does that?
So GNAV is what we have, and NEC is our vendor. And so, but again, it's from 1999, so it's patched, and patched. I'm really setting when I come back up for the...
Good job, Joy.
Okay, Joy, you're done.
Preparing her budget
The
conversation.
technology, to your point, is ancient, really. It really is. I had a quick question, Joy. There's obviously variations across the response to the in-basket messages when you look at these different clinics. So it's really a two-part question. First of all, how are the in-basket messages being routed? Is it standardized? I would assume not, looking at this variation. And then secondly, is there some effort to look at the best practices and then spread it across the network in a standardized way? So kind of a two-part question.
Yes, and to answer your question, again, I want to give a lot of credit to Dr. Sloan and Cheryl Edwards, who is here, because for our physician, our dyad group working with the teams for in-basket, that was one of our first items of opportunity. And I'll say this, talking about coming a long way, when I first got here, I remember in-basket message average turnaround time was 200 days. 200 days. So you want to know why people don't use my chart is because when they go to use it, it doesn't work for them. So now it's improved. And so how we are standardizing that now, so we started with specialty and we worked with that team. They're rolling it out to medicine. And then primary care is working with Dr. Henderson. So it's all about data and good data and then accountability of the data. So we talked about daily huddles with the groups. I'm CC'd on a report that comes that shows all of the in-basket turnaround times by area. And then we have a standardized approach of nurse leadership that sits in the clinic that is manning that to make sure that it's answered within a time frame. And then what happens is there's an escalation. So if something is not being responded, then it kicks up to that next level. And so we have a lot of eyes on it, which is helping. But to your point, adoption, it's an educational process, right? So physicians, we work with the physicians to say, okay, maturing that message so it's meaningful when it gets to you, and educating and standardizing that part of it is an ongoing process that we're still rolling out and educating teams to. And so it's incorporated in our onboarding for new MAs and LVNs that come on, and then we track it with the data to see how we're performing.
Okay, thank you. Because to your point, the 200 average turnaround for doctors was because everything hit their index.
Everything, yeah.
You cannot possibly be a practicing physician and manage all those messages all day long. So.
And that's why our physician engagement was so important. And when we talk about clinical basket pools and business pools, it was, one, making sure who is in the pool is the right person, and that was wrong before. And then what goes to the pool is what should go to that pool. And then when people leave, making sure you clean up the pool to make someone's, it sounds like we're swimming here, but swimming in messages, really. But
we were drowning before. We're dog paddling now.
Right.
So we're
coming out. And to your point, we've had calls with different organizations to talk about best practices because we want to learn. And so, I think when you think about ease of contact in clinic, I really think that goes back to the in-basket work, because the in-basket message is when the patient calls the call center and wants to talk to the clinic. That's the forum for that, right? Mm-hmm. So a nurse calls them back, or whoever that is that's appropriate.
To be a good relationship in looking at what's going in that basket, who's looking at it, and where they're directing it in the clinic. Because I hear you said that the doctor's getting all of those. My doctor doesn't get a whole bunch of that. There are other folks that, if it's lab, that's taking care of appointments and all of that. So as long as we are looking at, most of the time, it's almost like I get a scheduled appointment to talk to my doctor. Mm-hmm. And because everything else is taken care of by the support staff. Right. And so it's really, most of the stuff coming in, the doctor is not needed to be involved in that. But that has to be the process that's set up in those physician practices.
That's right. And that's where I go back to it. Each physician group, you want it standardized, but a specialist is different than what a primary care doctor needs. So we are involving our physicians in that conversation, because it's same thing to, like, if you go to my chart and it's broken, you're not going to go back. If the physician isn't getting what they need, they're not going to. So we're trying to make it easier for them, because we know, we're like, hey, doctor, we need you to see more patients, and how can I make that more efficient for you? So kudos to Dr. Alawi. And I say that because this is a big effort.
Well, I will say that it is better. It is much, much better on using my chart and messages. It is.
Still, I'll tell you this, we're dedicated to continuing to drive
Said it
forward.
was better. I didn't say
Yes, it was the best, that's right.
Okay.
Any other questions? Thank you very much.
Good report.
All right, next agenda is patient experience. Welcome.
Hi, good afternoon. Carla Koiva again. I am here to present to you patient experience. I'm excited to actually be here. This is my first time presenting on our patient experience. I'd like to go over our fiscal year 23 goal and where we are in our 6 focus areas, our current state, and some of the changes that we're putting in place, which is highly exciting for us in patient experience and has created a pretty good buzz with our clinicians at the hospital level once we started our soft launch. And so real quick, so where are we from an org goal perspective? As you can see year over year in fiscal year 22 versus 23, we are sitting at about 74.9% weighted average. As a reminder, this is our top box score for 6 service lines, with the questions are really around overall rating. So it's one data point that we are looking at across the different service lines. And it's, as you can see, we've stabilized, right? And it's the same, essentially same scores year over year. And we thought this was a good opportunity for us as a team to look at, do we have opportunities to serve our patients better? And in working with the team in patient experience, we had really intense conversations about what is a service delivery that our patients deserve. And even outside that, just from a service perspective, we ask ourselves, is it good for our patients to have multiple contacts, right, to be able to meet their needs? And so we really dug deep and came up with some innovative approach. Just to give you a perspective of where we are currently, in any given moment, just from our team alone, there are multiple contact points. We have our care ambassadors who are taking care of service recoveries. We have our language service employees providing interpreter services. And then we also have team members calling, checking on patients upon discharge. And then, of course, that doesn't include our spiritual care and ethics, and they also receive a survey. So this is truly our jumping off point in asking ourselves, where are we from a patient experience perspective? And looking into what the data is telling us. As you can see here, the data is showing us that our scores have stabilized. We're not seeing any major jumps or dips in our scores, and so we felt that this is the perfect opportunity for us to reinvent our approach in patient experience. Again, keeping our patients in mind and considering the service standards, we wanted to come up with a better way to really provide service to our patients that is more beneficial to them. And so what we had come up with is, if you look at, again, these 3 roles, we consolidated these roles into one position. And so patients now have one point of contact when it comes to any non-clinical needs that they might need. These positions will be embedded in the unit, so they are a part of the clinical care team. And we are calling them the patient experience specialist or patient experience specialist interpreter. So the delivery of care will be the same. It's delivered in English or in a language that the patient prefers. The beauty of this is we really want to work alongside our clinicians to ensure that our patients are rounded on regularly, that all their non-clinical needs are met. So these, our patient experience specialists will be assisting with admission. They will have a welcome packet. They will also assist with discharge. And so talking about ease of scheduling, we want to be there with our patients, making sure that they do have their follow-up appointments prior to being discharged from the hospital. We also want to build that relationship with the patients so that when we make that call upon discharge, they know to expect it. They know we can say, Mrs. Smith, we are going to be calling you and checking on you tomorrow. Make sure that you are available around 12, or let us know when you want us to check on you. So we are having meaningful interactions with our patient, being proactive with their needs, and being the true liaison between our clinicians, the family members, visitors, and the rest of the staff. So far, we've been able to launch a soft launch in a few areas. In the ED, a couple of inpatient units as well. And again, it's so well received by clinicians, primarily our nurses, because they now have a go-to person when it comes to assisting them with patient care. So how do we know that we are successful? Obviously, we want to track our Press Ganey scores, and the good thing is we are able to track that on a weekly basis almost immediately to see if what we're doing is truly making an impact. We also want to reduce complaints and grievances. On a monthly basis, we have about 20 to 30 complaints that we are dealing with, and we are expecting for that to be reduced now that we're a little more proactive with the needs of our patients. We also want to complete discharge call across the board of our discharged patients, and again, improved follow-up appointments. We are also looking at our baseline prior to soft launch so we can, again, track our improvement scores from a Press Ganey perspective. As far as community health is concerned, we are going to be working closely with community health in the next couple of weeks as well to roll out our soft launch in 4 areas: the Northeast Medical Home, Family Health Clinic, Surgical Specialty Clinic, and Polytechnic Health Center. So going back to our inpatient, as you can see here, just in the last 4 quarters, looking at our scores year over year, we are confident that by being more proactive with meeting the needs of our patients, that we could truly make a huge impact in the patient experience. Our soft launch also will allow us to tweak our processes, our workflow, our staffing as appropriate, and we will be monitoring our data week by week to ensure that we are hitting the marks. And so we are in the midst of creating our schedule for the next couple of months and phasing in our rollout throughout the rest of the network. Okay. Any questions for me?
I do.
Yes,
what
ma'am.
happened when I get to the CHCs? Do I still call that specialist? Because that's where the contact is going to be, so.
Yes, ma'am. We will have specific patient care specialists assigned to community health clinics. And their primary, they have a few goals there. One, we know that wait times is an issue with clinics, and so we will be there proactive, doing comfort rounds, possibly assisting with education around my chart. Assisting education on what to expect during their appointments. So we looked at the volume by clinic, and we've decided to match that volume on the number of specialists that we might need there. And we will tweak on as needed basis as we go through the soft launch, but our patients will always have a single point of contact, and our provider as well, to be able to build those relationships.
All right.
Okay.
Hey, Carla, just a quick question. It looks to me like you've got 62 people that were previously doing this role, not including spiritual care. I don't know how many FTEs that corresponds to, but 62 people. How many people are we talking about, or FTEs, for your future state?
Future state, we're looking at truly around the same number of employees. Again, we are testing the model to ensure that we are appropriately staffed. Currently, we have not made any major changes in our staffing model. What we have made changes on is a workflow. And instead of making calls for an interpreter to be there, the interpreter will already be there to provide assistance. For example, in ED, originally, interpreters will be rounding. Now we have assigned 3 full-time individuals in the ED to catch all of the comfort round interpreter needs of our patients.
So 24/7?
24/7, yes. However, there will be minimum staffing from 8 p.m. until 6 a.m. So we will have a group of people who are considered floaters. And so as our patients are sleeping, there may not be a huge need to be in the unit that whole time. So we will have a set of people that will be rounding across the hospital.
And I'm sorry, another question. And I may have missed it, so I apologize. The soft launch already occurred?
We started last month with training, and so we're 2 weeks, we missed, we had our winter storm. That was our second week of our soft launch, so we are just in the second week of that.
So the data is probably not representative at this time?
Say that again, I'm sorry.
The data that I don't know which slide it is, but the data with the 4 graphs on it, I would just say that's probably not representative yet.
This is our current data.
Yeah, it's the emergency department E3 tower, 6 tower, 11 slide. That data is probably not entirely representative yet. I mean, it looks pretty flat, to be honest with you.
It is. This is actually our current data, ending fiscal year 23 Q1.
Okay, so this does
yes.
not represent any changes after your...
That is correct, yes, not yet, correct. So I'm excited to present next time to see how we've made an impact.
Yeah, but, okay.
Make a good point, raising hand up.
Because you got a lot of folks calling, and now you're going to have one point of contact, so.
And how
Joy
long
got
does it-
people calling, and everybody got folks calling, so the coordination of that would be
How
critical.
long does that one contact stay with the patient? Okay,
Right.
that's a good question.
The community health model is going to be slightly different, and so we have yet to really dig a little deeper with them.
I do understand that, but the bulk of the community health situation is walking in that area, coming mostly from a referral from the hospital. So
Inpatient
that
to
is the inpatient. So having that contact is a great deal so that they will be there. I know in the CHC you're going to have someone there to help them navigate too. I do understand that.
Thank you.
Okay.
Joy, you heard that? Okay.
Any other questions?
No, good report.
Thank you.
All right, thank you, Carla. All right, next, we will move on to the quality matters requiring committee action and/or approval. And we have 2. Welcome back.
Thank you. So I have 2 policies to present. They were both up for their renewal. One is National Patient Safety Goal 700, Never Events Management. We had some minor edits, adding mainly ownership of the different action items listed in this policy. It's been approved by PSQG and MEC and now here for your approval.
Anybody have any questions? Okay, I have a motion to approve and a second. All in favor, say aye. Aye. Any opposed? Next item.
All right, National Patient Safety Goal 1200, patient notification of unexpected outcomes. This had even less edits. Again, has been through PSQG and MEC, and it's just up for its renewal.
All right, entertain a motion for that. Any questions?
Move approval.
Move approval. Do I have a second? Second. All in favor, say aye.
Aye.
Aye. Any opposed? Okay, motion's passed. Thank you.
Okay.
Now we're going to move into executive session. Let's take a 6-minute break and be back at 10 till.
Gee.
You can tell a physician moving through a room, sign that.
That's it.
Room and
To adjourn in a second. So moved. Second. All right, we are adjourned.